welcome everyone. My name is Twin and I am the program coordinator. Sorry, apologize, that's my old title. Um, I am the program manager at Community Health Resource Center, and we are a nonprofit that has been serving San Francisco Bay Area for over 35 years. And this is my information on the screen. I oversee free health education and health screenings. In a moment, you'll hear me talk a little bit more about them. But the four main areas of our nonprofits serve as services are behavioral health services, nutrition counseling, health screenings, and health education. And I have to do this because it's the end of the year campaign, but thank you for bearing with me. We'd love it if you could make a gift and pay it forward for our expansion of community health screenings and mental health services. Any amount of donation will help, whether it's $10, $100. Once you provide us with funding, it's really all going back into the community, and we would love to continue expanding our resources. I'd like to get now into the tips for this webinar today. If you'd like to raise your hand, go ahead and do so on your computer screen. You can click the three little dots next to your name and raise your hand. We'll unmute you so you can ask your question out loud. If you are dialing in, you can raise your hand by dialing *9 or unmuting yourself with *6. You can also connect with us or interact with us during the presentation via chat or Q&A. We will answer questions at the very end. And if you registered and submitted questions, we'll also have questions there, although not all of them will be addressed if they're not directly related to today's lecture. But some of the questions that came in during the registration are relevant to a presentation that we did just a few weeks ago. So I encourage you to explore our library online for these video recordings. I will also include them in the post-event email to everyone here today. Now, I'd like to introduce Dr. Milana Dolezal. She is we're welcoming her back for the third time this year. She's a wonderful speaker. She's a board-certified oncologist and hematologist who treats women's malignancies and gastrointestinal cancers. She is a lead researcher enabling new approaches to the treatment of solid tumors and I already mentioned that, but hematologic malignancies. And she's currently the medical director for Cancer Survivorship Program Comprehensive Cancer Center. Thank you. I am tripping over my words today.
All right. Thank you. Welcome, everybody. Couple things I wanted to mention as well. So the Community Resource Center is really helpful. It's downstairs in the 2100 Webster building, and it has nutritional support, psychosocial services. So it's really great for patients to tap into that. It is a sliding scale in terms of some of the support services that they have available. Just to be clear, I am a volunteer. This talk is free. I am not getting paid. But if you could contribute anything to the fund, it really helps support other patients and their families who have cancer in terms of the needs that are out there, especially with the pandemic. We found that the psychosocial needs are very high. So thanks everybody for coming today. I'm Dr. Milana Dolezal. I'm a medical oncologist, and I subspecialize in breast cancer. This topic of HER2 positive breast cancer is near and dear to my heart, as it's a very changing and evolving and exciting new field in terms of some of the newer therapies. With that being said, I also worked at Genentech back in 2005 to 2009 on some of these HER2 directed agents, and even worked with the FDA on the adjuvant Herceptin filings for the joint analysis in 006 that we're going to talk a little bit about. And there's a lot of newer therapies out there that are exciting. So today, this is going to be what's new in HER2, a breast cancer overview. A disclosure, I do speak for several different companies, some of which are HER2 targeted agents, which I will discuss today as well. So I'm pretty involved and aware of what's new in this field. All right, so just talking a little bit of background in terms of breast cancer in the United States. 1 in 8 women develops invasive breast cancer. So you look around at your sisters, your mom, and your best friends, and you can probably find a room of 8 people, or at least 1 or 2 people have probably experienced breast cancer in some shape or form. Let's not forget about the men, though, because about 1% of breast cancer can also be in men, often in patients who have a family history, or even without a family history, gene testing, genetic testing, which is saliva and blood, testing for mutations from mom or dad is really important in that population. Now, of the subsets of breast cancer, we talk about sort of 3 targeted receptors that are important that are on the outsides of the cancer cells. So there's the estrogen receptor, there's the progesterone receptor, and then there's the HER2 receptor. And HER2 positive breast cancer is about 50 to 20% of the breast cancer that's out there. It does tend to be a little more common in younger women, so women either of childbearing age or have young children at home, where certainly hair loss and these things are a big issue for our young patients. And it does tend to be a more aggressive type of dividing under the microscope type of breast cancer, often grade 3. But over time, it does seem to decrease in frequency as women get older. So that's a little bit about the demographics. What does that look like on a cellular level? So HER2 itself is pretty specific for cancer cells. It's really found only on cancer cells, with the exception of some young heart cardiomyocytes. That's why we do frequent heart testing with ultrasounds or MUGAs. But for the most part, it is on a breast cancer cell. And as I mentioned, 15 to 20% of breast cancer cells express this. This was what it looks like if there's abnormal HER2 expression. And these are the extracellular receptors that are on the outside of the cancer cell. And you can see quite a few of them. There's 2 ways that we test for HER2. It can be via protein expression, something called immunohistochemistry, which is the slides are stained with the antibody looking for that protein expression. And 3+ is considered positive. That's a brown staining. 2+ is intermediate positive. And then we do a different kind of confirmatory test on that breast cancer tumor biopsy called FISH or SISH, in situ hybridization. And that's a different way to measure for HER2. As I already alluded to, the HER2 receptor can be overexpressed on between 15 to 20% of the breast cancers out there, and typically more aggressive and more poor prognosis. However, we have many great therapies out there that are predictive for HER2 agent benefits. So what are all those therapies out there? So this is a busy slide. I'm going to show this to you a couple different ways, a couple different times. So you can see here the different types of HER family receptors on the outside of the cell. And again, these are extracellular, I call them trees sitting on the outside of the breast cancer cell. But there's a whole family of HER1, HER2, HER3, HER4, and I'll talk about why that's relevant. So focusing here on the HER2 portion, you can see that there are monoclonal antibodies. So these are IV treatments that bind to that tree, and I'll explain that a little bit more. And that's trastuzumab, also known as Herceptin, which binds to sort of the trunk of this HER2 receptor cell, and then extracellular receptor. And then pertuzumab, also known as Perjeta, binds to the outside of this receptor as well, but more on the branches. And those are some of the antibodies that work by binding the outside of the cell. We also have some magic bullet, as I call them, antibody-drug conjugates. And that's what's depicted here. You see a backbone of a HER monoclonal antibody, but you see these little things here. Those are actually chemotherapies that are linked to that particular backbone of the antibody. And some of the ones that are out there are TDM1, which is Kcida, and we'll talk about in HER2, deruxtecan, which is another antibody-drug conjugate. And then we have sort of turbocharged type of Herceptin, something called margetuximab, also FDA approved. I've highlighted all the ones that are FDA approved. So these are all the antibodies that are binding to the outside of the breast cancer HER2 positive cell. But then we have small molecules that are pills that actually work differently. They work on the inside of the cell, and they basically bind and block the different cancer signaling pathways. So this is sort of downstream and going into the nucleus and stopping cancer cell division, proliferation, survival, and causing cell death. So we'll review this a few times, but that's a nice sort of overview inside, outside of the cell. And so this is busy, but this basically dives into what I just explained. So what kind of targeted therapies are out there? So there's big antibodies that bind the outside of the cell. They're generally intravenous, or they're given as shots. Some people might be on something called Figoso now, which is a combination of both Herceptin, trastuzumab. There's always two names of these agents. There's the generic name and the trade name, and pertuzumab together. So either IV or shot. They have a very long half-life, which means they stay in your body for a long time. So that's why they're dosed generally every 2 or every 3 weeks. Herceptin, Perjeta, TDM1, all those agents are dosed every 3 weeks. So that means sitting in an IV chair every 3 weeks. They're really very large molecules. So these monoclonal antibody biologics can't really get up into the brain. And I'll talk about why that's relevant. They target the outside of the cell, as I showed. And they're generally specific to a target. So the antibody is going to something on a cancer cell. And there's a lot of different ones out there now, too. It's not just about HER2. And because it's given IV, there really aren't a lot of drug-drug interactions. So that's sort of the left side of the slide here. Well, what about those small molecule inhibitors that I discussed? So those are oral pills. They have a short half-life, meaning once you swallow them, you know, they go away quickly. They're metabolized often by the liver or the kidney. So generally, those kinds of pills are dosed every day, or maybe even twice a day. They can get up into the brain tissues. They target mostly the inside of the cell. They're what are called tyrosine kinase inhibitors. So they block specific parts of cancer signaling pathways. Sometimes it can actually have more toxicity because they can hit multiple different pathways. So often they can cause things like a diarrhea or rash, and we'll talk about that as well. And because they're pills that you take and they go through your body, you can have what are called drug-drug interactions with other medications that you might take. So keeping that in mind in terms of any acid-reducing pills, etc. So let's go back to sort of one of the mother antibodies here, monoclonal antibody biologics. This is Herceptin, which is the trade name, also known as trastuzumab. This is an anti-HER2 specific monoclonal antibody that binds to the outside of those HER2 positive cancer cells, binds with high affinity. It's mostly humanized, which means it has less infusion reactions as opposed to some of the older antibodies, for example, that Genentech makes, like Rituxan. Rituxan is more mouse, and that's an antibody that's used for multiple different types of conditions. But Herceptin is mostly humanized. let's talk a little bit about the different types of therapy where these HER2 agents can be used. So you might have heard of pre-operative therapy versus post-operative. So operation being the breast cancer surgery, which could be a lumpectomy, also known as a partial mastectomy or a mastectomy. On the left side, it outlines what neoadjuvant preoperative therapy is and what are some of the goals. Well, one of the goals is to shrink the tumor, possibly to make the surgery more successful. But it's not just about the surgery. There's a lot of other things that we can learn by giving the HER2-focused therapies up front. If we do a combination of HER2 antibodies along with chemotherapy. And we usually do about 6 cycles every 3 weeks. And the goal there is to actually shrink the tumor to the point where there's no tumor left at surgery. And that would be either in the breast tissue or underneath the lymph nodes in the arms. And that can actually be predictive of benefit and also future recurrences. So having no tumor left at surgery with about 5 months of upfront therapy is a good prognostic sign as well. It can sort of tailor our therapy based on response. If it's not working that well after about 3 cycles, we might shift gears and do something else. Newer therapies are also looked at as sort of a playground to understand the activity in certain clinical trials, like the I-SPY trial that UCSF has had for several years now. And generally speaking, for any tumor that's at least 2 centimeters or greater, that's HER2 positive or triple negative, we do upfront therapy prior to surgery. Well, what about adjuvant therapy? That's post-operative therapy. So surgery has cut out all the tumors, possibly a sentinel lymph node, and then this is the treatment you receive after surgery. The idea is to get rid of any micrometastatic disease and prevent any future recurrences. So that's the difference between pre versus post-operative therapy. So what were some of the landmark studies that looked at the monoclonal antibody Herceptin added to chemotherapy after surgery in the adjuvant setting? These were some of the clinical trials that formed the basis of the FDA approval of Herceptin trastuzumab in the post-operative adjuvant setting. And these are the names of the trials. These 2 trials here were combined in the joint analysis. And you can see here that basically, I'm not going to describe what the letters mean. It's basically chemotherapy plus minus Herceptin. And the addition of Herceptin had an over 50% reduction in recurrence risk of the HER2 positive breast cancer coming back. The 006 trial was another trial that looked at a specific 3 different arms with the addition of Herceptin, but also a newer type of regimen back then called TCH, which has been more of a standard of care. The T stands for Taxotere or docetaxel. And again, you can see that all of these trials, and over time, we've really gotten much better in terms of treating and hopefully curing early stage HER2 positive breast cancer. And you can see the timeline there. So here I talk about the tree again, and just to try and differentiate the differences between some of these antibodies. So I mentioned trastuzumab, Herceptin. That binds to the trunk of the tree there. So that's the extracellular HER2 receptor that's on the outside of the cancer cells. And that blocks the downstream inside the cell signaling. But pertuzumab Perjeta, which is an agent that we use in multiple settings now in HER2 positive breast cancer, that's what's called a dimerization inhibitor. So what these cancer cells can do is they can bind to other members of the HER2 family to stop signaling. And so the 2 cancer cells can sort of kiss each other with the branches of their tree to then divide and grow. Well, pertuzumab as an antibody comes in and binds to the branches of that tree So those two nearby cells can't downstream signal and kiss each other. And that's just a depiction here. You can see that it's a dimerization inhibitor. So the pertuzumab blocking these two agents, these two receptors, cancer cells next to each other from binding to each other, it binds to the branches of the tree, so then those cancer cells cannot signal. And then you stop all of this downstream stuff from happening. These agents, Herceptin and Perjeta, were studied in the early preoperative breast cancer setting in different trials. One was the Neosphere trial, and this was all before surgery, either in combination with chemotherapy or even in arm C without any chemotherapy. And you can see here that going through about 6 cycles every 3 weeks over about a 5-month period, when these patients went to surgery, whether it be a mastectomy or a lumpectomy, partial mastectomy, that anywhere between 16 and 45% of the patients had what's called a complete pathological response with no tumors left at surgery. And it seemed to be more pronounced in the patients that had HER2 positive but estrogen or progesterone negative disease. And you can see the rates, percentages of pathologic complete responses here. Well, what about some of the other even newer therapies out there? I love this idea of directed targeted therapy, the magic bullet idea. So here you can see this is what's called an antibody-drug conjugate, very sophisticated technology. So you have your antibody, which is the Y here, which is basically a Herceptin trastuzumab type of backbone, but then linked here to that Y, you actually have chemotherapy. And in this case, the cytotoxic, which is chemotherapy agent, is TDM1. And that's what these little pink circles are. And so you actually have a train that's bringing the chemotherapy directly to the cancer cells that are HER2 positive. And then the chemotherapy is released inside the cancer cells. So you don't have the same side effects as chemotherapy going throughout your whole body. So often patients who are, for instance, on TDM1 can get their hair back or keep their hair, etc. So keep this in mind in terms of this magic bullet idea. Here you can see that you have the antibody that's going to bind to your HER2 positive cells linked to the chemo, and the chemotherapy is now going inside those cancer cells, going into the DNA, stopping it from dividing and ultimately killing those cells. And for the most part, those linkers only will let go of the chemotherapy inside of the cancer cell. It has to do with the pH of the cell and some proteases and other stuff, but you don't really release the chemotherapy throughout the rest of the bloodstream. TDM1, which is the magic bullet that I just described, was approved by the FDA back in May of 2019. And this was in a specific patient population. So these are patients who had HER2 positive breast cancer that all underwent pre-surgical therapy. And then when they went to surgery, they still had tumor left over. So they did not have a pathologic complete response. So they had residual tumor in the breast or the axillary lymph nodes. And then they either got what was prescribed at the time as standard of care to a total year of post-operative Herceptin versus switching to TDM1, the magic bullet. And here you can see that basically there was a decrease in recurrence risk by 50% of using TDM1 over Herceptin. And that's what you see here. A hazard ratio of 0.50 means a 50% reduction in risk. And this is compared to Herceptin, which is still an active agent in the post-operative setting. Here you can see here the differences in terms of disease-free survival, but I just wanted to point out a theme here, which is going to be relevant to some of the future discussions that we have, that when patients did recur distantly, about 5% of the patients in each arm actually recurred in the brain. And part of that I will describe is those big antibodies can't get up into the brain. So the brain sort of remains unprotected from the HER2. So it's kind of like going to battle without a helmet on. You have all this armor, but you have no helmet to protect your brain. So let's talk a little bit about a case so you can kind of put this together for yourself. So this is Linda. She was postmenopausal, 61 at diagnosis. She had a stage 2B HER2 positive, but also estrogen and progesterone positive breast cancer. She underwent preoperative, pre-surgical neoadjuvant therapy with 4 agents, 2 HER2, 2 chemos, TCHP, and she did that for about 18 weeks. She had some side effect of diarrhea from the pertuzumab. And then she went to surgery. She elected to have a mastectomy, but did not have a pathologic complete response, meaning that there was still tumor left. And then she underwent TDM1 per the Catherine trial that I just described, and she did that for 14 infusions. So keep her history in mind. And this is what I like to think about in terms of sort of chapters of therapy. There's the before surgery, and then there's the after surgery. She also underwent radiation therapy to the lymph nodes, as she had 5 positive lymph nodes at diagnosis. And that was around the time that she had started the TDM1 IV magic bullet therapy as well. So this is always a sobering slide for me because it shows that even though all these great agents are out there and reduce risk of recurrence by 50%, there's still patients who can recur with HER2 positive disease who had an originally early breast cancer that we hoped was curative. So this shows you here all these different trials that I had outlined before, but the bottom line is anywhere between 25 to 31% of the patients on those trials at 10 plus years of follow-up did have recurrences, often distant recurrences, some of which included the brain or liver or lungs or bones or other locations outside the breast. Here you can see the Catherine trial, which was for those higher risk patients that had TDM1. There was, even at 3 years, a 12 to 17% recurrence risk. So why does that happen? So these agents haven't completely eliminated the risk of recurrence, and something called HER2 escape can happen. And there's a lot of different mechanisms of resistance. I'm not going to go through all of them, but I just want to give you a little idea of how that can happen. Well, I mentioned that antibodies bind to the outside of the cancer cell, to that HER2 or HER family receptor. Well, the cancer can get tricky and they can sort of shorten that receptor or do something to the receptor. They can truncate it, and so those antibodies cannot bind anymore. Sometimes the body cannot develop enough of an immune response to then have the antibodies be effective. Sometimes what can happen if it's also an estrogen positive tumor, patients will continue on an anti-estrogen pill daily for at least 5 years. Well, if you're suppressing the estrogen aspect of cancer signaling, but you haven't suppressed the HER2 aspect, you can get this seesaw idea, and then the HER2 family can now upregulate again and sort of rear its head and start signaling. And that's the idea of sort of the crosstalk here and upregulation and some of those downstream cancer signaling pathways that have been known to cause that upregulation and resistance both to HER2 and even estrogen are the PI3 kinase and the PTEN cancer signaling pathways. And I know this is a lot of science. I just want to give you really high level ideas of sort of what is all the science back there and what have we all been studying all these years. Well, the good news is there are, in 2021, 8 FDA-approved targeted agents in the metastatic setting. So we've really gone a long way. I've mentioned pertuzumab and trastuzumab that are used in the curative breast cancer setting, as is T-DM1 used in the curative breast cancer setting. But there are a lot of other medicines out there. Neratinib, I'm also going to discuss, that's a small molecule inhibitor that attacks the inside of the cell, that is also approved in the curative setting for estrogen and or progesterone and HER2 positive breast cancers. And again, you can see here the theme of what binds on the inside and what binds in the outside. So I've already talked about trastuzumab, pertuzumab. I'll talk a little bit about turbocharged Herceptin, margetuximab, that was studied in the SOPHIA trial. I've already mentioned T-DM1 as Kadcyla in the adjuvant setting. I'll talk about another magic bullet, antibody-drug conjugate in HER2. And this is, again, just a schema of where these drugs are working. But the FDA was really busy during this pandemic and basically approved tucatinib in the stage 4 setting, in HER2 in the stage 4 setting, neratinib in the stage 4 setting, margetuximab in the stage 4 setting. And I've worked with the FDA. They're incredibly understaffed, so I'm not sure how they accomplished all that during a pandemic. But it's great for patients as we have a lot more options. So just to review this again, I've showed this a couple of different times. So I mentioned what drugs are FDA approved already, and I talked you through some of these agents and where they're working. So I'm not going to talk too much about margetuximab. I like to think about it as a turbocharged Herceptin. Generally, it's used in the later line setting, but it's FC receptor engineered, so it binds better, really causing more downstream kill, and really works on the body's immune system to help the drug work. So keep that one in mind. I mentioned a lot about brain metastases, CNS metastases as an unmet need. And when you look at the early breast cancer studies, I mentioned the Catherine trial with T-DM1 causing a decrease of risk of recurrence of 50%. But the patients that did recur, over half of them unfortunately recurred in the brain. And then similarly, the Affinity trial, I didn't show you that schema, but that was looking at pertuzumab added to Herceptin after surgery. And of the patients who had a distant recurrence, about 35% of those patients had a distant recurrence in the brain. And unfortunately, once the disease becomes metastatic, then it's no longer curable, it is treatable. And up to 50% of patients over the treatment of their stage 4 metastatic breast cancer will develop brain metastases. And I'll show you more of that data as well. So this just brings that home. I showed you some of this data before in terms of these patients recurring anywhere between 15 to 33%. But then you start to see where they're recurring as well, the brain metastases are an issue, even up to over 50% in the highest risk patients on that Catherine trial that had residual disease at surgery. So what is the deal there? So there's something called a blood-brain barrier that acts as a sieve, so large things can't get up there. I think a lot of this dates back to caveman times where maybe we ate a poisonous mushroom and it would make us sick, but it wouldn't get up into our brain and kill our brain tissues. But what that means clinically is a lot of these biologic therapies, these large antibody IV therapies, they're not getting up into the brain. And I gave you the analogy of like going to battle without a helmet on. The brain remains unprotected from HER2 positive breast cancer cells. And that's because of this tight layer, and these big therapies can't get across it. And even in patients who have a stage 4 HER2 positive metastatic breast cancer, a lot of these patients can be asymptomatic, meaning they can have brain metastases, but they don't have anything on a physical exam, or they don't have anything in terms of signs or symptoms. And that can be anywhere between 15 to 30% of patients. And I'll talk about the HER2 CLIMB trial, which actually included patients who had active brain metastases. And about 26% of the patients on that clinical trial, their brain metastases was only caught at screening by doing an MRI of the brain when they entered onto the clinical trial. Again, no signs and symptoms. So that practice has really changed my clinical practice in terms of I do brain MRIs on patients who have HER2 positive metastatic breast cancer at least twice a year, or if there's any sign or symptom in the stage 4 setting. Here you can see too that the brain can be a common site of metastases of up to 50% during the course of the stage 4 treatment. And it can even happen as early as the second line therapy, and that shows you the breakdown. And I've unfortunately had patients who've also presented with seizures or something many years out from what we had hoped would be curative HER2 positive breast cancer treatments. So Nerlynx is a pill that you can take. It's a small molecule tyrosine kinase inhibitor. It hits many of the HER2 family members, and it's the only agent that's actually approved both in the early curative and late stage breast cancer setting that's HER2 positive and hormone receptor positive. It can cross that blood-brain barrier. It's this little boomerang down here, and it's what's called a pan-HER inhibitor because it can inhibit HER1, which is EGFR, HER2, HER3, all these different what are called hetero and homodimers. And this was studied in the extended adjuvant setting. So actually after a year of HER2 IV therapy from year 2 to 3, and the idea was to really protect the brain from those HER2 positive breast cancer cells going up there. This was in the early setting, about a 5% absolute benefit, and in high-risk patients who did not have a pathologic complete response, at least a 7.4 absolute benefit. And that was in the curative HER2 estrogen or progesterone positive setting. This was the extranet study design that I talked about. I'm not going to go into all the details, but basically all patients finished their whole IV therapy. And then after that, from year 2 to 3, they had a pill for a whole year. And I showed you the data in terms of the absolute benefits. One side effect that's important to mention is diarrhea. On that initial clinical trial, a lot of women had a lot of diarrhea, and grade 3 diarrhea, that's like 7 stools a day, which is a big deal, even if you're working from home with a bathroom during a pandemic. But really, we've learned how to use this drug much more effectively. There was the control study that tried to figure out, well, how can we control this diarrhea? And the best strategy, which it was called a dose escalation. And so you actually start with half dose, 3 tablets, and then you work your way up. I generally try to get patients to 6 tablets around month 2 or 3 or by 6 weeks. But you ratchet up the dose, and that dose escalation strategy really, really helps the side effect profile. This particular small molecule inhibitor pill was also studied in the stage 4 HER2 positive breast cancer setting, along with an oral chemotherapy, also known as Xeloda or capecitabine. And the 2 endpoints in the stage 4 setting were progression-free survival or overall survival. These were actually third-line patients, and I'll discuss the lines of therapy. They had all had at least 2 lines of therapy in the stage 4 setting. And there was an improvement there. So going back to Linda, so unfortunately, she had a recurrence in her central nervous system with brain metastases. Unfortunately, she did have high-risk disease. And I think if Linda was my patient after she had completed all that therapy, given that it was estrogen positive, I probably would have given her Nerlynx at that time. But at this time, we're faced with brain metastases now. So what do we do for Linda? Well, an option that was FDA approved in April of 2020, again during this pandemic, was another small molecule inhibitor pill called tucatinib. It's actually approved in hormone receptor, I'm sorry, HER2 positive, not exclusive to hormone receptor positive. I need to change that on the slide. It is a potent HER2 selective tyrosine kinase inhibitor, and it goes into the CNS. It's also even been studied in patients who have what's called leptomeningeal disease, also in the spinal fluid. And this was based on the HER2 CLIMB study, which looked at patients who had at least one line of prior therapy in the stage 4 setting. And so this was a second or third line greater study. And the idea of the combination is you're targeting the inside of the cell with a HER2 directed agent, a small molecule inhibitor pill, but also the regimen includes Herceptin. So you're binding to the outside of the cell with Herceptin, and then it's paired with chemotherapy as well, Xeloda chemotherapy. And the primary endpoint here, again, was looking at what's called progression-free survival. In this clinical trial, almost half of the patients had brain metastases at diagnosis. And as I mentioned earlier, about 26% of those patients, 23%, excuse me, at a baseline MRI were discovered to have new brain metastases. And then 40% of the patient had stable brain metastases. But this was really new in terms of allowing patients with brain metastases on a clinical trial. And kudos to Seattle Genetics for doing that, CGen, because in the past, a lot of those patients had been excluded from clinical trials or limited in terms of who was allowed on the study. So they actually allowed 60% of patients who had active brain metastases onto the clinical trial. Visceral metastases also means disease in the liver or lungs. So almost 2/3 of those patients, 75% had disease also in other sites. And about 59% of the patients in each arm also had estrogen positive breast cancer in addition to HER2 positive. Overall, it was a positive study. Here you can see the curves. I don't expect you to understand what that means, but you can see in terms of progression-free survival, there was about a 2.5 months advantage, and in overall survival, there was a 4.5 or so month advantage by adding this small molecule inhibitor to a combination of chemo pills and Herceptin. This was sort of the overall study summary here. And so reducing the risk of progression by 46% from 5.6 to 7.8 months. Overall survival reduced by 34%, 17 months to 21 months. And in the patients specifically with brain metastases, more than 50% reduction in progression or death. And so really clinically meaningful for those patients who have a HER2 positive breast cancer in the second or third line or greater setting. Here's an example of our NCCN guidelines. These are our National Comprehensive Cancer Network guidelines. And I just want you to keep in mind, so this is January of 2021 for HER2 positive disease. These are standardized across the whole world. And these are some of the different regimens that are available. And I've talked you through some of these, but this is even evolving within the last few weeks. And I'll show you some of that data. So to go back again, all the different drugs that are out there. So this is looking again inside of the cell versus outside of the cell. And here we are in August of 2021. And now you see more granularity there in terms of these lines of therapy that I've mentioned. So first line, I'll show you that data. Second line in the stage 4 HER2 positive setting. And this is evolving as well in terms of TDM1. And then tucatinib's also in the second line setting. I just showed you that HER2 climb data, especially patients with brain metastases. And then there's your third line and beyond. So this is my schema. I'm going to present it again after some new data. But first line setting, these are the lines in metastatic stage 4 disease. Second line setting, and I just make a mental note of all the complexity that's here in terms of the decision making. So I like to think now that, you know, we're kind of more like a chef and not a cook, because we really have to personalize patients' care in thinking about what agents we're going to use. So when I talk about first line setting, that's in the stage 4 spread out outside the local breast area, so unfortunately not curative, but still very treatable. This was the Cleopatra data. This has been sort of the standard of care for probably about 5 years now. And you can see the improvement here with the addition of pertuzumab, so again, that dimerization inhibitor, to Herceptin and chemotherapy. Well, what about the magic bullets? Where do they play into this? I showed you the schema earlier for TDM1. Well, TDM1 was studied in the second line setting in the Amelia trial. You can see the data there. So overall, an improvement. Here's the breakdown in terms of first line overall survival of about 56.5 months based on that Cleopatra study. And then second line, almost 30 months. After that, there hadn't been a clear standard of care in the third line or greater setting. So here's another newer kid on the block. This is another magic bullet, an antibody-drug conjugate. So here's your Herceptin again, but linked to a different kind of chemotherapy. This is what's called a topoisomerase inhibitor type of chemotherapy. It's a relative of irinotecan, which is an agent, a chemotherapy agent we use a lot in gastrointestinal malignancies like colorectal cancer, for example. And so here you can see a few differences. So this is your antibody backbone, so your train, your magic bullet that's going to bring the chemotherapy directly to the HER2 positive cells. It has a much higher ratio of chemotherapy compared to, for instance, TDM1 Keytruda. And currently this is approved in the third line or greater in both breast cancer, but also in HER2 positive gastric cancer in the second line setting. So this is an exciting newer kid on the block. This data is amazing. So this is actually in the second line setting. This was presented less than a month ago at the end of September at the big European oncology meeting. This is looking at second line stage 4 HER2 positive breast cancer at TDM1, that's Keytruda, versus this Enhertu agent. And these patients had an incredible response with almost an 80% reduction in disease recurrence in the stage 4 cancer setting, to the point where some of the medians are still not reached. These curves separate very broadly. Again, I don't expect you to understand the significance, but this is how FDA approves drugs, based on this clinically meaningful difference. And again, this is not yet approved in the second line setting, but I anticipate maybe even by the end of the year or next year, it will be approved in this setting. It's currently approved in the third line setting. And this is overall survival. In the area where this agent is improved, this antibody-drug conjugate, it was shown in a phase 2 study, which formed the approval for the FDA to melt tumors. And what that means is overall response rates. That's a combination of a complete response, so all the tumors went away, versus a partial response, where at least a 30% reduction in all the tumor size. And you can see here, that's what comprises this response rate. And here's the breakdown in different types of patient subsets, but really remarkable data to the point where the FDA actually approved this in the phase 2 setting, and multiple phase 3 trials are underway. So it's really a magic bullet in terms of melting tumors. This data was also updated at the Big Oncology Conference at the end of the year, and everything was consistent. The safety profile was also similar. This agent can cause a type of lung inflammation called interstitial lung disease that can manifest as cough, shortness of breath. Fortunately, with the pandemic, everybody pays attention to cough or respiratory symptoms, but a grade 1 is even symptomatic, and that could be just a cough, and this drug does need to be discontinued in those circumstances. And there's lots of help in the package inserts from the FDA approval about how to screen for interstitial lung disease. So here's sort of another update in terms of with that new data I just showed you. This is, again, MD, that's me, my personal algorithm that I think about in terms of treatment of stage 4 breast cancer, HER2 positive breast cancer, first line. And again, it depends on what patients have received in the curative setting. I think in HER2 will probably make its way up based on the data I just showed you. Whether or not there's brain metastases also plays into whether or not you're going to do a small molecule inhibitor. But you can see that the field is really just opened up broadly in terms of treatment options, and still really an unmet need in terms of those stage 4 HER2 positive breast cancer patients. But patients are living longer with a better quality of life. What's also nice about some of the pill options is you can keep your hair. And here again, so this treatment is evolving. This is just in August, and I anticipate in January of 2022, this is going to even look different. So I always like to show pictures of Angela Jolie as Maleficent during October, which is Breast Cancer Awareness Month, and also Halloween. Just a little bit of a comment in terms of her role in breast cancer awareness. As you recall, the New York Times op-ed in terms of her disclosing her BRCA positive results from her mom. And there was something called the Angela Jolie effect, where patients were getting more mastectomies after. But I think public knowledge about this made genetic counseling and awareness a lot more available to patients to talk about. And one last thing, just to talk about another trial looking at a different class of drugs called PARP inhibitors for patients who have BRCA mutations. This was also just presented at our oncology meeting in the US, the ASCO meeting in June. These are patients who had germline mutations from mom or dad with a family history. And this is a PARP inhibitor that was used in the curative breast cancer setting, but it's already been approved in the metastatic setting. And this was the Olympia trial. And this also showed a clinically meaningful, almost 50% reduction in recurrence risk. And the safety profiles can be, it can cause some blood count issues and kidney number elevations. And the conclusions from that clinical trial are here. Just overall, this is now another treatment option approved by the FDA for patients who have germline mutations. Okay, so I think we are almost up on time here. So that is the conclusion of what I had to say. And we have a few questions here.
Yeah, we have a few questions that came from registration, but I do want to address some that directly came after your slides.
Okay.
Susan wants to know about the patient story you shared. How did Linda know that some tumor was left in breast even with mastectomy?
So when the surgical specimen is submitted to pathology, they look under the microscope to see how much tumor is left in both the breast and also the lymph nodes. So when I say tumor left, it's tumor left in the surgical tissue that's cut out. This is not necessarily tumor left in your body. Now, Linda had positive lymph nodes. So per our guidelines, she would qualify for doing a PET CT scan or a CT scan and a bone scan as part of her initial staging to make sure that she didn't already have stage 4 spread breast cancer. So when we talk about a pathologic complete response, it means the tumor that's still in the surgical specimen that's already been cut out of your body. Now, we do look at margins, and generally we have to have about a good centimeter margin or so in terms of, you don't want tumor left on ink in terms of surgical ink. So if you've had a lumpectomy, the surgeon might need to go back and cut more out, or we use radiation also in those lumpectomy situations. So that's what that meant. So tumor positive breast tumors, triple positive. Yeah, so that is HER2, estrogen, and or progesterone positive. So generally treated very similar to how I mentioned, but an anti-estrogen pill would also be included after radiation therapy is completed. And that could be a combination of things. For premenopausal women, the options are to do like a Lupron shot prior to even chemotherapy be starting, continued through chemotherapy, and even after with an aromatase inhibitor, anti-estrogen. Or the other option for premenopausal women is to use tamoxifen. Postmenopausal women, we generally use an aromatase inhibitor. In the case I showed you with Linda, who had basically a triple positive type of tumor that was also lymph node positive, I would have given that patient neratinib, which is that small molecule inhibitor that is approved in the early breast cancer setting for years 2 to 3 after the IV therapies, and that can help prevent brain metastases as well.
Dr. Dolezal, I think that we'll jump around a little bit based on some of the live questions coming in. Susan, who also asked that question, wanted to see, are there recent studies of HER2 treatment without prior chemo or HER2 treatment?
I'm sorry, say it again?
Yeah, are there recent studies of HER2 treatment without prior chemo or prior HER2 treatment? I think.
I guess I'm not understanding that. So there are a couple of different aspects of that question, I suppose. I referred to the Neosphere trial that had the arm C that had no chemotherapy. That was Herceptin, Perjeta alone. There are other de-escalation trials out there. There's the ADAPT trial. There are also the Compass HER2 trials that are looking at a different way to do chemotherapy. For instance, the Compass HER2 trial is only Taxol therapy weekly times 12 with Herceptin and Perjeta. So there are clinical trials out there and a lot of de-escalation strategies in terms of not using as much chemo or maybe just one chemo. So ADAPT, ADEPT, Compass. I think that answers your questions.
Okay. And there's Marla, who would like you to specify by what you mean early stage HER2 plus, who can benefit from Nerlings? Does that include stage 1 with or without node involvement? Additionally, you don't seem to have 12 weekly Taxol plus Herceptin alone as an option for early stage triple positive BC. Do studies show this as less effective than adding Perjeta or other chemotherapies?
Yeah, so those are all sophisticated questions. So again, this was an overview. By no means was this was as close to soup to nuts as I could get in just an hour. But so two aspects of this question. So you don't seem to have Taxol weekly. So let's talk about that. So that is the APT trial, which is the Tolany trial, Sarah Tolany's at Dana-Farber. And that is that looks at Taxol weekly, I alluded to that just now, times 12 with Herceptin and Perjeta. Now that same regimen is being studied in the preoperative neoadjuvant setting. before surgery, and that's that one of the Compass HER2 trials that I alluded to. So that is out there. Again, the two nuances of that is the Compass neoadjuvant trial is a trial, but could consider that as an option for patients in the early neoadjuvant setting. The APT trial was basically a single arm type of study, so it's not a big randomized trial. But it is considered another option, certainly for lower risk patients. So it, all depends on what the clinical characteristics are and that sort of stuff. In terms of specifying early stage HER2, so lymph node involvement would not be a stage 1. So who am I using Neuralinks in? So again, this is a discussion to have with your oncologist. So it is approved for patients who have hormone receptor positive, so estrogen and or progesterone positive, and HER2 positive disease. That's really the patient subset that has benefited the most. I think patients who have not had a pathologic complete response, that's a class to think about it in addition to lymph node positive tumors. Now, just as another answer to that question, and this is again my clinical hat, there's a different Compass trial that's looking specifically at tucatinib with TDM1, so Kate-Sida, in patients who have not had a pathologic complete response. And I actually have a few patients on that clinical trial. We do have it at CPMC, and that's a different Compass HER2 trial. So currently still being investigated.
Thank you, Dr. Dolezal. And I think this will have to be our last question if you have the time. I will have to send everyone a post-event email. I think someone did request your references for the information on the slides. If you could share links to articles you've referenced with me, I'll make sure participants get them. The last question is from Joanna. What is the AI with least chance of diarrhea? She started anastrozole when still on Herceptin and Perjeta and had terrible diarrhea.
Yeah. So Perjeta itself causes diarrhea. Usually the body can get used to that. I've been transitioning a lot of patients away from the IV Herceptin and Perjeta and to Phesgo, Phesgo. That is actually a shot that combines both Herceptin and Perjeta together instead of having to sit in an IV chair. You could have your port taken out. That seems to have a little less diarrhea, but remember, Perjeta alone causes diarrhea too. In terms of the AIs, boy, I've had different patients who've really suffered. Letrozole seems to cause diarrhea. I haven't seen it as much with anastrozole. So possibly cycling through some of the aromatase inhibitors would be an option in terms of seeing which ones might cause less diarrhea. So maybe going to aromasin instead. And if that gives you diarrhea, Femara. Generally, I would take people off for at least 2 to 3 weeks to give them a break, let it kind of wash out, and then try a different aromatase inhibitor, or the other option is to go to the Phesgo shot. I don't even know if I'm pronouncing that right, in terms of understanding if that's what causes the diarrhea.
Okay, I think that will have to be the last question. I thank everyone for joining us today. Unless Dr. Dolezal, you have time to answer our other questions, but
just one comment about the references. So a lot of references were included on some of the slides. There's probably at least 20 references, if not more. So maybe if you want to be a little more specific in terms of which references you were interested in for which clinical trials or which agents or what, because that would be a pretty big endeavor to try and go through and itemize all of them. A lot of them are on the slides. Okay, so we already talked about ways to test for HER2. So generally speaking, immunohistochemistry, which is measuring the protein, that is an antibody that goes on the tumor, and the protein expression of HER2 stains brown, and 3+ is considered positive. 2+ is intermediate positive for protein expression. And then we do something different called ISH, and that could be either FISH, which is fluorescent in situ hybridization, which measures brightness. It's based on centromeres and chromosome 17. Again, that's a pretty nitty-gritty question in terms of the two traditional methods to check. The Oncotype DX test is used predominantly for estrogen or progesterone positive HER2 negative breast cancers. It can give a quantification of HER2, but it's really not approved for HER2 positive breast cancers. The other way that we pick up HER2 is more relevant in terms of the stage 4 cancer setting, and that can be mutation testing through panels. So these are gene mutation panels, next generation sequencing. There's different platforms out there. So there's Foundation Medicine has a next generation sequencing platform. Caris is another one that I use a lot that has gene mutation platforms. So that's relevant more for stage 4 cancer, where you might look for like a PI3 kinase mutation. You can look for HER2 mutations in that setting. There is data in estrogen positive, HER2 positive lobular cancers that can have HER2 mutations, and there are some ongoing clinical trials looking at neratinib, Neralinx with Faslodex and other anti-estrogen treatments. So how long can one expect to be on medication for endocrine therapy? So the standard of care is 5 years. There is a different test that I use clinically called the BCI, the Breast Cancer Index. I covered that in the anti-estrogen talk. And the BCI test goes back to your tumor from 5 years ago from your surgical pathology, and has two components, prognostic, but also predictive, as to whether that cancer that you had 5 years ago would benefit from longer than 5 years of an anti-estrogen therapy. So that's called the BCI Breast Cancer Index. And it is FDA approved and insurance approved in Medicare and other types of insurances. So you can look up BCI. It's also in the NCCN guidelines since January of 2021. So you can ask your oncologist about getting a BCI test. Lumps in my armpits, that's often something to be worried about. COVID vaccination can cause the lymph nodes under the arm that was vaccinated to be enlarged. So generally we tell patients avoid any mammograms or MRIs or PET CT scans for a good at least 4 to 6 weeks after you've had your COVID vaccine. But if you if you have metastatic disease and it's time for you to be restaged, they always ask, which arm did you have the COVID vaccine in? With that being said, if none of those things apply to you, you should have a targeted ultrasound and get breast imaging again if you are a breast cancer survivor, and certainly call your oncologist about this. PAL-B2, so that's sort of known as a BRCA3. There are a lot of different tumors or genes, genetic mutations that we're discovering now with the large gene panels, Invitae, Myriad, Ambry. These are all germline testing, mom, dad, who gave you a potential cancer gene. PAL-B2 is considered like a BRCA3. So we are doing mammograms and MRIs alternating every 6 months in those patients. But you should see a genetic counselor to discuss what your surveillance needs to be. There are other genes out there that we've discovered over the last 5 or so years, like CHEK2, which puts you at a breast cancer risk, also colorectal cancer, about a 2-fold increased risk. So it's really specific to the gene. So there, I think we're out of time. I think I got most of them covered, but thank you everybody for joining, and I appreciate your time. Hi, Jane. It's nice to see you. And Marilyn, got a couple of shout outs there to people. So thanks for joining and taking the time today to listen to the talk. And again, tried to be as soup to nuts as I could, not super scientific, but I love the science behind all this stuff because it's super cool.
Thank you so much, Dr. Dolezal. I really felt that you helped us bridge all of that really, really nitty-gritty science into something that, well, at least for me, that I could understand better. I really appreciate you generously taking the extra time to answer all of our participants' questions. If anybody else has questions, you can feel free to email me and I'll try to get in touch with Dr. Dolezal, perhaps regarding any specific references you wanted to look into, and I'll ask her. Please
Yeah,
let
and
me know.
ask your oncologist these questions too, in terms of some of the data that
Absolutely.
was reviewed. So I'm not going to go into the nitty gritties of a stage 1A and that kind of stuff, but you should feel that you have an open communication with your oncologist to say like, hey, I heard about this new therapy. Does it apply to me? Okay.
Thank you so much.
All right, everybody. Thanks again.
Have a great week.
Okay. Bye-bye.
Bye.